All right, today we're doing a deep clinical dive into one of the most common arrhythmias you'll ever see in practice and for sure on your board exams, the premature ventricular contraction, or PVC. Let's get right into it. It's a feeling a lot of people have had, that sudden flutter or a big forceful beat that just feels off. This is often the classic way a patient describes a PVC. So right away, we know this isn't just about squiggly lines on an ECG. It's about a real and often pretty scary patient experience. And that experience brings us right to the heart of the matter, the big clinical question we have to answer every single time we see one. Is this just a harmless, isolated thing, or is it a warning sign of something much more serious? That's what we're going to unpack today. To answer that, we've got to start with the fundamentals. From a pure electrophysiology standpoint, what is actually happening inside the heart during a PVC? The name itself tells you pretty much the whole story. It's premature because it fires off early, before the next normal beat from the sinus node is due. And it's ventricular because it starts from an irritable or ectopic spot somewhere in the ventricular muscle itself, completely jumping the chain of command of the heart's normal conduction system. Now, this slide is perfect for understanding why a PVC looks so weird on an ECG. A normal beat starts up in the SA node and zips down the heart's electrical superhighway, the His-Purkinje system. This is super efficient. It depolarizes the ventricles quickly and in sync, and that gives you a nice, narrow QRS complex. A PVC, on the other hand, starts in the muscle and has to spread slowly from one cell to the next, kind of like taking the slow, winding country roads instead of the highway. And all that extra travel time is exactly why the QRS complex it creates is so wide and bizarre looking. So after this chaotic beat, you almost always see a characteristic pause. Why does that happen? Well, the PVC goes forward and squeezes the ventricles, but it usually doesn't travel backward to reset the SA node. The SA node is basically undisturbed, just marching along to its own beat. So it fires its next signal right on schedule, but that creates this noticeable gap after the PVC. We call that the full compensatory pause. Okay, so let's take all that physiology and see how it shows up on an ECG. Once you know these clues, you'll see how they build into a pattern that's actually one of the easiest arrhythmias to spot. Here are your 4 high-yield features for diagnosis. First, a wide QRS complex, over 120 milliseconds, because of that slow side road conduction. Second, there's no P wave right before it, because the signal started in the ventricle, not the atria. Third, you'll usually see a discordant T wave. That just means the T wave points in the opposite direction of the main QRS. It's because that abnormal depolarization leads to abnormal repolarization. And finally, that full compensatory pause we just talked about. These 4 things are your bread and butter for nailing the diagnosis. We also classify them in a couple of ways. If all the PVCs on the strip look exactly the same, we call them unifocal. That means they're all coming from one single irritable spot. But if they have different shapes and sizes, they're multifocal, coming from multiple different spots. And that's clinically important. Multifocal PDCs suggest a more irritable ventricle, and that's generally more concerning. We also describe their pattern, like bigeminy, where it's a normal beat, then a PVC, normal, PVC, or trigeminy, where every third beat is a PVC. Okay, so we can identify a PVC, we can classify it. Now we circle back to that central question. How do we decide if it's a real problem? The very first step is to think about the cause. Sometimes it's something totally benign, stress, too much caffeine, not enough sleep. But it could also be a major red flag for some serious underlying pathology. Things like ischemic heart disease, electrolyte problems like low potassium or low magnesium, or even drug toxicities. Digoxin is the classic example you have to remember. When it comes to PVCs, context is everything. A single PVC in a young, healthy person with a totally normal heart, usually benign. But that exact same PVC in a patient who has a history of a heart attack or has a weak heart muscle from cardiomyopathy, that's a whole different ballgame. We also get worried when the PVCs are happening all the time, when they're multifocal or when they're causing serious symptoms. So, what do we mean by frequent? Well, here's a key number to remember, both for your exams and for your clinical practice. If a patient's PVC burden is greater than 10 to 15% of all their heartbeats over a 24-hour period, that's a big deal. At that point, we start to worry that the PVCs themselves could actually cause or worsen a cardiomyopathy. Now, let's talk about a very specific, very high-risk situation that you absolutely must be able to recognize in an instant. This is the R on T phenomenon. Because the answer to this question is pretty simple and pretty scary. It's when it happens at exactly the wrong time.
The T wave on an ECG represents the heart's ventricles resetting, or repolarizing. It's a period where the heart muscle is electrically vulnerable. If a PVC fires at the precise moment of the peak of that T wave, what we call the R on T phenomenon, it can hit when some cells are reset and others aren't. This creates absolute electrical chaos and can be the trigger that sends a patient into a deadly arrhythmia, like ventricular tachycardia or even ventricular fibrillation.
So, knowing all this, how do we actually approach a patient in the clinic? Let's walk through the clinical workup and a good management strategy. A patient might tell you they feel palpitations or those classic skipped beats, though honestly, a lot of people are completely asymptomatic. The workup is really logical. You start with a 12-lead ECG to confirm the diagnosis. Then, a Holter monitor, which is a 24-hour ECG, is crucial to figure out that PVC burden we talked about. And finally, an echocardiogram is absolutely essential to check for any underlying structural heart disease. That remains the single most important factor for prognosis. Management follows a really clear, stepwise path. For an asymptomatic patient with a totally healthy heart, the best thing you can do is offer reassurance and advise them to avoid triggers like caffeine or stress. If they're symptomatic, beta blockers are a great first-line choice to help calm things down. And for our high-risk patients, we get much more aggressive. We treat the underlying disease, and we might consider antiarrhythmic drugs or even a catheter ablation to go in and zap that irritable spot. All right, for everyone studying for exams, listen up. This next section is absolutely critical. Let's lock in the key differences between PVCs and the things they're commonly confused with. This table right here is your exam cheat sheet. The biggest differentiator is the QRS width. A PVC is wide because it starts in the ventricle. A premature atrial contraction, or a PAC, is narrow because it starts up in the atria and travels down that normal His-Purkinje highway. And the difference between a PVC and ventricular tachycardia? Well, VT is a sustained rhythm. It's 3 or more of those wide beats in a row, while the PVC is just a single, isolated event. Okay, let's do a super fast summary. A PVC is a premature beat from the ventricle. On an ECG, you're looking for a wide QRS, no P wave, and a compensatory pause. In a healthy heart, it's usually benign, but you have to watch out for the red flags: frequent PVCs, multifocal patterns, any underlying structural heart disease, and of course, that dangerous R on T phenomenon. And that brings us to the end. The next time a patient describes that classic skipped beat feeling, you now have the entire framework. You can identify the arrhythmia, you can understand its cause, you can assess the risk, and you can formulate a solid plan. You'll know exactly what questions to ask and precisely what to look for.